10 years. I will confess to you that I am not overwhelmed by the benefit of adding 5 years of tamoxifen to an initial 5 years of tamoxifen for a variety of reasons that I could get into if we had more time. And finally, you could also say this is a very high-risk patient. I would have put her on an aromatase inhibitor and ovarian suppression up front. I'm just going to do it now. That strategy has worked in postmenopausal women. I don't think you would be wrong to do that. But you just have to realize that there has not been a study that has specifically done that. My general view of hormonal therapy is that it works whenever you do it. And whether you initiate something at year 5 or at year 2 or even at year 7 or 8, as Paul Goss showed in the group of women who had been on placebo and then were started on an aromatase inhibitor, I think you get an effect no matter what. I haven't given
Professor
you a
Conti, please. You have to.
Can I just add one thing? I would just add that the study allowed up to 8 months out from chemotherapy, so there's still time for people. What? You got wiggle room there too. And when you do switch people, which I've switched a lot of my higher risk folks, I've tend to been somewhat sequential. So I keep them on their TAM, I suppress their ovaries, I say come back in a couple months and let's see how you're doing, and then I'm going to switch them over to the AI, because you can't give the AI right away unless they're suppressed. It won't work.
Okay. Professor Conti, please.
Yes, I see that on the program Eric Weiner is named Eric Winner, so he must be right, certainly. So we have some very young patients who still wish to have pregnancy after 5 years of tamoxifen, and they can get pregnant after 5 years of tamoxifen. Do you have any data about fertility after ovarian function suppression and an aromatase inhibitor?
Oh, sure. So I think that the issue about ovarian function suppression is really time. There's not any evidence, nor is it biologically expected, that ovarian function suppression would cause in and of itself infertility in the future once someone's off and the drug has worn off and the effects. But it's the time it takes. And most women are not getting breast cancer at 20. They're getting breast cancer in their 30s and 40s. And so yesterday I showed a curve of where fertility really plummets, even in the general population, and it's in the mid-30s. And then if someone has gotten chemotherapy first, then the ovarian reserve is even lower. So it's a real issue and a real negotiation for these women. And they have a small window if they are going to try and get pregnant after they complete their endocrine therapy or take a break.
Okay. Go ahead.
Thanks a lot. My question about we are hearing about the using of chemotherapy against endocrine therapy, like the older Zebra trial comparing the chemotherapy against CMF and other trial comparing the ovarian function suppression against FAC. My question is any subgroup of premenopausal women with high risk, lymph node positive, and tumor size, large tumor size, can we spare them from chemotherapy and give him ovarian function suppression plus tamoxifen? Because you know that chemotherapy, as Dr. Heba said, is a very terrific for the young woman.
Yeah.
The answer is almost certainly yes, but the problem is selecting those patients. And so the higher risk someone is based on tumor burden, the more it makes me nervous to back off on chemotherapy, even in the setting of a cancer that I think is biologically one that is going to be much more sensitive to endocrine therapy. In truth, in young women certainly with multiple positive lymph nodes, we don't get, for example, an oncotype because we don't even want to know the result because we're not going to act on it. I think that this is something that needs to be studied further in the future. I don't think we have an answer to it right at the moment. Now, that does not mean, however, that every premenopausal woman with positive lymph nodes in my practice gets chemotherapy, because she certainly doesn't. But the ones who don't aren't the patients with 6-centimeter tumors and 7 positive lymph nodes. They're women who have relatively small tumors, certainly T1, small T2, and a limited amount of lymph node involvement.
Sir, the Berkay trials is addressing this question or not? Berkay trials are addressing the chemotherapy.
Berkay.
Yeah, addressing. Is any update about the news of these trials? It's a larger trials, an old trial like the soft and text, and until now we didn't hear about the update of this trial.
Yeah, unfortunately, Perkay never succeeded, and it had to be closed because there was essentially no accrual. In a sense, the Taylor X trial, in which Oncotype was used to identify a group of patients who were thought to have an intermediate biologic risk, and patients both pre and post were randomized to chemotherapy or not, will answer this question. It doesn't specifically include patients who are premenopausal and node positive, but if in fact in that group of patients there turns out to be no benefit for chemotherapy, it's going to give us all a pretty strong signal in terms of what we could expect in node positive patients as well.
Okay. Thank you very much. Now you will ask for the conclusion. Ladies and gentlemen, even in the most common disease among women and in very common kinds of treatment like neoadjuvant or adjuvant, endocrine treatment, systemic chemotherapy, even we don't have answers to many questions. So the answer for this is clinical trials. So I urge everyone in this room to participate and try to be involved in clinical trials to answer many questions to come. Now I thank you very much for your attendance, and I hope to enjoy the rest of this meeting. Thank you very much.